intensive rehabilitation program for difficult pain conditions. He was also instrumental in setting up first women's pain center and children's hospital in 2009, where he had the position of director of the Women's Pain Center between 2009 and 2018. And he did lots of work in the region there, and he was clinical lecturer at National University of Singapore from 2011 to 2018, and associate professor lecturer at the Faculty of Medicine and Surgery at the University of Santo Tomas, Philippines. Please, Bernard.
Is it all right now? Yeah, okay, thanks. Thanks, Amar. Appreciate your kind introduction. It's been a pleasure for me to come and join you in your scientific program. It's an excellent program and an excellent meeting. So without further ado, I got 25 minutes to so-called exchange my views regarding about how to treat low back pain using annuloplasty. Discogenic pain is a major cause of non-specific low back pain and plus minus radiculopathy as well. Out of all of that kind of back pain, 39% of that is due to internal disc disruption, and we can find that when there is a concordant pain due to provocation with discoplasty. Interestingly, is that once this kind of pain settles, it is very difficult for the pain to go away and can persist in up to 80% of patients. A lot of this discogenic pain is due to degenerative disc, or the DDD, and this is due to the disorder of nucleus pulposus, rupture of the annular fibrosis, injury of the cartilage end plate, as well as the ingrowth of all the free nerve endings and granulation tissue into the annulus fibrosis, and as well as even nucleus pulposus. Apart from all this degenerative change, we do know that there are some healing mechanisms such as growth factor, fibroblastic growth factor, macrophages, as well as mast cell that will play a role in the so-called healing or recovery of the injured annulus and therefore subsequent disc degeneration. So when there is a discogenic pain, we always know that there is first the disc itself loses its hydrostatic pressure, and that results in delamination, fissuring, microfractures of the collagen fibrils. And once that happens, over time, there is sensitization of nociceptors and ingrowth of all the painful free nerve endings, and subsequently resulting in the release of a lot of the prostaglandins, as well as a stimulation and sensitization of the dorsal root ganglia. So when it's still within a contained disc, and it's just a disc degeneration, when does this proceed or progress to something like a disc herniation? So there will be nuclear migration, there's annular weakening resulting in the bulging of the disc, and this bulge can progress to nerve impingement, whether it's mechanical or chemical, and resulting in back pain as well as radiculopathy. Once the herniation reaches a certain size, then that becomes a mechanical problem itself. It's no longer just discogenic pain. It becomes a mechanical, as in compressive problem, whereby the approach to that problem is somewhat different. So the algorithm of discogenic back pain, axial back pain, intolerance to sitting, whereby during examination the back pain is not elicited. It's not elicited by pressure on the paraspinous muscles. Back pain that doesn't respond to all the conservative kind of treatments, like such as medications or physiotherapy and physical therapy. No previous back surgery. There's no obvious disc herniation whereby the size of the disc herniation is not significant. No stenosis, no spondylolisthesis, and there is possible evidence of an annular tear evidenced by a high intensity zone on the MRI, and plus minus a positive provocation on the discogram. So when we see an MRI and we see a black disc or DDD, we say that, okay, this back pain can be due to the disc itself, a discogenic type of pain. If you look at the so-called herniation, not much of herniation, very minimal. As the disc progresses, or in other patients, the degeneration of the disc itself can result into a disc herniation with minimal or insignificant canal narrowing and canal stenosis. What are those patients that are not suitable to consider annuloplasty? Unsuitable will be whereby if this herniation has gone past a certain stage of a 2A, whereby it has reached beyond the facet joint itself. We want to confine or restrict ourselves to patients whereby it's just mild disc bulge, very mild disc herniation. The moment you see this type of this herniation, I would say that annuloplasty does not have a role. It will progress on to, you can have a combination of annuloplasty plus a decompression of the disc, whereby the mechanical effect on the nerve roots or the mechanical effect on the disc herniation is more significant than just the discogenic pain itself. So first of all, we always will move towards trying to do a discogram, whereby it is the gold standard. If you have a positive pain provocation, when you do a opening pressure of 15 to 50 psi of opening pressure, or 60 centimeters of water during injection of the disc itself. The pain should subside after local anesthetic injection. So once we have diagnosed that this patient possibly is suffering from a internal annular destruction or this degenerative disease, patients will always go through a whole gamut of different treatments. They will try to do what we call the conservative physiotherapy, pain management, physiotherapy, whereby there's rehab as well as even acupuncture and multidisciplinary pain approaches. On the other end of the spectrum, the patients might even undergo surgery. But however, the surgeons will come back and say that surgery, especially fusion, does not give them very good results, and they may end up with what we call failback surgery syndrome. So this group of patients have always been now stuck. They don't have a way to go forward because physiotherapy or conservative may not necessarily help them. Open surgery, they have had very poor response or poor results with that. So what do we have to offer these group of patients? So there are different types of treatments that have been so-called put forward to help patients with discogenic pain. There's this FX using bipolar radiofrequency at the nuclear annular junction. We can even go more invasive using endoscopic annuloplasty and uteroplasty. People have tried epidural and wasn't very successful. The numbers needed to treat for these type of axial pain has been pretty poor. Various treatments of the disc itself, such as steroids, ozone, methylene blue, even biologic preparation, has not been very conclusive in terms of the treatment. Annular thermal procedures has been used widely to be able to help this kind of internal annular disruptions with fairly reproducible results, applying a model of ablation of the inflamed nerves to be able to stop and resolve the pain. I'll walk you through some of the different approaches of applying this thermal annular procedures, such as IDAT, flex stroke, or even bioplasty. The principles of annuloplasty itself is that we want to be able to eradicate the painful granulation tissue, whether is it thermally, through radiofrequency ablation, through laser, or through mechanical or manual elimination using forceps or using endoscopes or whatever. So on one hand, there is mechanical ablation. The other part is a thermal destruction of the nociceptors. At 45 degrees, they will result in all this thermal destruction. At 60 degrees, there will be a denaturation, shrinkage of the surrounding annular collagen fibers to be able to cause a contraction of the annular fiber, thereby giving a perception that there will be a volume reduction. To string the annulus, to enhance stability, plus minus even to apply a pulse radio frequency intradiscally. Effectiveness of annuloplasty all originated when they first mooted the idea of using IDAT reported by Sol and Sol in 2000. So in IDAT, in the next slide I'll explain, they will apply the catheter to be able to loop into the disc itself to reach the posterior annulus by looping it all the way around. So once the catheter has looped around to the posterior annulus, achieves to try to denature the collagen fibers and to denervate the posterior annular fibers itself. So some of the reviews have shown that yes, the effectiveness of thermoannular procedures in treating discogenic low back pain has somewhat fair evidence of getting a reproducible results. It all started with that. I'm just wondering, apart from the thermal ablation of the nociceptors itself, can it also cause a mechanical decompression, whereby it will be helpful for disc bulges with nerve irritation, nerve impingement, resulting from what we call a volume reduction, especially in those with contained discs, or possibly even functionally helping, whereby there is no nerve compression, but when we go in and we burn and we apply the annuloplasty, it will result in reduction of the nerve irritation. So for IDAT itself, when the idea first came about, it was popularized by Nick Bogdo, Australian pain physician. In his hands, he has wonderful results with regard to IDAT. I had the fortune of trying out this IDAT, and I would say that yes, there is certain reproducible results that we can actually achieve for discogenic type of pain. The IDAT itself, you can see that we put in the needle to the center of the disc, and we float a catheter, a spine cap, that will loop itself to the posterior annulus to where we think the painful nerve fibers or nerve endings are. So this is how it looked. It is not always easy to navigate that IDAT catheter because especially in degenerated discs, the DDD itself, the black disc syndrome, hardened disc can make it extremely difficult to navigate. It can even king the catheter. It can even cause the catheter breakage. So, but if we have placed it correctly in the nuclear annular junction, applying a temperature of 90 degrees, that will achieve a annular temperature of 60 to 65 degrees, thereby resulting in ablation of the painful nociceptors. Because of some of the difficulties related with the IDAT spine cap, so the industry has moved on with newer so-called modalities such as flex stroke. A flex stroke needle, a flex stroke cannula, will be able to, because of the J-hook, as you can see here, be able to get itself into the posterior annular space. And once that happens, the J-hook here, it will be able to site it ipsilaterally to where we feel that the pain signals might be. And because it is much more stiff and steerable, even in the degenerated disc, a hardened disc, it is not too difficult to be able to achieve a placement of the posterior and lateral intervertebral disc itself. And once we are there, we are able to achieve the ablation in a very reproducible manner. So positioning of the patient. Okay, there are different ways of applying this needle into the disc itself. Commonly, when we first start out, we are always taught to do a tunnel vision, Scotty dog, straight in. The trouble with that is that you may end up in what we call a 45 degrees entry point, and it may not necessarily slide into the annular, into the posterior annulus. The catheter itself can actually go forward and go into the intradiscal space rather than into the posterior annulus. So, but usually that's how people always start off, trying to place it in a Scotty dog view, 45 degrees, tunnel vision, and on. I would say that we will try to aim towards a Camden triangle down here, whereby if we go by measurement from the midline, it's about, if it's an alpha 5, it's about 10 to 12 centimeters from the midline. And when we enter in from the lateral space, it will slide in nicely, and because of the J-hook of the needle, it will sit nicely, after I'll show you, into the posterior annular space. If the needle is not placed correctly, if it's too shallow an angle, what may happen is that you actually come out of the disc itself and enter into the posterior epidural space. Sorry, anterior epidural space, right? And that is the problem. That means your flat stroke catheter is going to, when you lesion it, is going to cause heat injury. If it's too steep, what will happen is that it will go right into the center of the nucleus and you're actually doing a nucleoplasty rather than annuloplasty. So just now I was mentioning Scotty dog, at this angle, we enter in. I would say that we would rather aim for a Camden's triangle at a 10 to 12 centimeters from the midline and enter in better. And then keeping our mind on where we call it the medial radicular line. So this is, once we have placed the needle, we apply the catheter to the flat stroke catheter to enter in. And more importantly, it is actually the lateral. You can see that I'm actually at the posterior annulus, and you can see that the catheter itself curves posteriorly rather than going anteriorly. So when you go anteriorly, we are doing a nucleoplasty, which we don't want to. We want to do an annuloplasty, so actually we want to kind of curve it posteriorly. So the first entry point is that we see the needle, the eye, and on. And secondly, as we thread the catheter through, you will, the probe through, you will be able to see it following the posterior annulus. Once we are in position, I will apply a step lesion, what we call a step ablation, rather than a standard ablation. So starting from 50 degrees, this temperature is ramped up slowly, progressively, up to 70 to 90. Depends on where I feel the probe is placed. If I'm very close to the capsule of the herniated disc, contained disc, I don't want to be at too high a temperature. If I'm much further in what we call closer to the nuclear annular junction, then the temperature can be higher to achieve an annular temperature of 65 degrees. That will be able to be validated when I do a motor stimulation. When I do a motor stimulation and I find that the voltage is very low and I get a motor twitch, that means my probe or my catheter is too close to the posterior capsule, and I have to be more careful about hitting a high temperature. 5 degrees increment for every 30 seconds, final temperature of 2 to 4 minutes. If I do a standard ablation, once the temperature is reached, the energy is cut off, you don't get that ongoing ablation effect. So we want to do a step ablation rather than a standard RF ablation. These are some of my own statistics. I have, over the last 4 years, we have done about 128 patients. 57% of them are females, 43 are males. A lot of them in this age group of 40 to 60 in this bag. So their pain all starts off in distress, their pain score is 7, 8 average. And after procedure, the first day, first post-op day, drops to 3. And we follow them up after 1 month, it drops to 2. Their functional improvement in terms of sitting tolerance or walking tolerance or radicular pain has increased by 70%, and most of them have a satisfaction of more than 4 out of 5. Some of the possible things that could go wrong when we apply an annuloplasty. The biggest we always worry about is the thermal injury. Because if the disc itself is quite flattened due to the degenerative disc itself, then the placement of the probe or the catheter, if it's too close towards the end plate itself, can result in what we call end plate thermal injury. Or if the catheter or the probe is placed too posteriorly to the capsule or the disc itself, then you may actually end up with dorsal root ganglion injury. Another possible problem that can arise from annuloplasty is discitis. It's almost the same as doing a discogram, and you can get a problem of discitis. Same thing with annuloplasty, it can result in a sterile discitis, and the patient can get accelerated degeneration of the disc. Alternatively, the last, which doesn't happen very often, there's a possibility of a disc herniation from the puncture wound, especially if we apply and try to get the flex stroke or that annular needle into that space multiple times. I generally will recommend less than 2 tries. If you do it like 5 times repeatedly at the same place, there's always a risk of disc herniation after the annular puncture, resulting in more progressive disc herniation. Why in some other patients, why in some other doctors' hands, there may be the results may not be so predictable. Number one, it could be poor selection of patients. Yeah? If we select a patient whereby the disc degeneration is very severe, while we say it's a BDD, a black disc syndrome, but if it's an extremely degenerative disc, very spondylotic, very calcified, you're going to have great difficulty getting to the right place. Number two, the sighting of the active tip of the so-called the radiofrequency probe and the catheter. We want to sight it exactly where the posterior annular fibers are, rather than in the anterior space. So too shallow, no good, too deep, no good. So we want to be exactly where we think that the painful nerve's ramification at the posterior margin of the annulus. Last but not least, we sometimes we have difficulty because of a hardened disc manipulating the active tip, and there may be a possibility of breakage or kinkage. With the flex stroke catheter, it's less of a problem. If you use a spine cath of the IDAT, definitely that's a big, big problem. Moving to a little bit more invasive, this is minimal, less invasive type of treatment. So there is an application using more herniated, targeting more herniated disc patients. So there may be a needle, a bigger needle now, whereby we go in there to be able to decompress the disc herniation as well as to apply radiofrequency ablation at the nuclear annular junction. Using a needle whereby it is a bit more invasive, it's a 3mm needle. We call this either the disc FX or the Maximal. They also have a very similar type of needle, a 4mm needle. We can actually apply it into the disc. We can actually decompress the disc herniation, a small disc herniation, mind you, and then after that we apply a radiofrequency ablation to the painful annulus. So that in itself will be able to ablate the nociceptors as well as to seal the annular tear. So this is the application of the introducer into the disc itself. After I have placed the guide wire inside, and then I go in there, I can decompress using manual forceps to physically pick off the herniated area of the disc, a small disc herniation. And then thereafter apply the thermal ablation for that. So applying the thermal ablation, whereby after we have decompressed this herniation, and then debulking the disc that has mechanically herniated up, we will apply the radiofrequency ablation, and we will be able to, we call it bipolar ablation on the nuclear annular junction. So, regarding about annuloplasty treatment itself, in conclusion, I would say that a lot of the low back pain, especially the non-specific back pain, can be due to a disrupted disc, such as a discogenic type of pain, or degenerative disc syndrome. And there's no treatment that actually can stand hip to hip, shoulder above the breast. As far as in my experience, I feel that the annuloplasty itself is trying to bridge that gap between very non-invasive type of treatment, like physiotherapy and all that, or even with fusion, whereby they not necessarily have a good answer to the solution of the non-specific back pain. Thank you for your attention.